The involuntary movements, okay, they are mainly chorea, athetosis, hemibalismus, dystonia, myoclonus, tremors, fasciculation, fibrillation, myokymia, and polymini myoclonus. Okay, so one by one we will discuss briefly about the involuntary movements. Chorea. What is chorea? Chorea is a quasi-purposive, involuntary, non-repetitive movements involved in the mainly the proximal parts of the body. So the quasi-purposive, what is the meaning? That means because the movements, patient want to do something, that is not his purpose, but he wants to do something to avoid that movement or to escape from the attention of the persons. That is quasi-purposive, involuntary and non-repetitive movement. How the chorea movement usually will look, okay? So usually the chorea movement will be like this, okay? Be like this, involving the hands or the legs. If one side of the body is involved, it is known as hemichorea. There are some causes of chorea. The chorea, the Indian subcontinent, till now it was the common cause was Sydenham's chorea due to rheumatic fever etiology. Hereditary chorea, Huntington's chorea. Drugs, oral contraceptive pills can produce chorea, thyrotoxicosis, pregnancy, cerebrovascular accident, non-ketotic hyperosmolar coma. So all these can produce chorea. In the chorea, the problem is in the caudate nucleus. Chorea, athetosis, hemibalismus is the same spectrum, but only the velocity of the movement differs. Athetosis will be a slow movement, chorea little faster, hemibalismus is a very fast movement. Athetosis is a slow ridging movement of the wrist involving mainly the distal parts of the body. The problem here is in the putamen. So how the athetosis usually looks like? See, there will be a slow ridging movement of the hand with adduction of the fingers and the forefingers and the hand, and then slight abduction. Then again slow ridging movements of the hand and the wrist, adduction and then slightly abduction. It's like a snake-like movement it will be like. Slow movements, athetosis. Okay. So next is hemibalismus. Hemibalismus is a violent, same like chorea, but it will be more violent and more fast. Hemibalismus. The problem in hemibalismus is in subthalamic nucleus. Okay, right. So the next involuntary movement which you have to look is dystonias. Dystonias, there can be a generalized dystonia of the body, that is abnormal position for a longer period will be kept, generalized dystonia. Focal dystonia and segmental dystonia. Segmental dystonia is one segment of the body. For example, the neck and arm will be involved. Focal is only one part of the body will be involved. A classic example of focal dystonia is cervical dystonia torticollis. If one side of the sternocleidomastoid is active, for example, if right side is active, the neck will deviate towards the left side like this. There can be both the sternocleidomastoid can be active. It is known as anticollis. There can be a retrocollis. Okay, that is a focal dystonia. The vocal cords can become intermittently active, producing a spasmodic dysphonia. So you can produce a voice which is very high pitched because of intermittent activation of the vocal cords, spasmodic dysphonia. Blepharospasm. Closely, they may close their eyes in between like this. Okay, they may close their eyes in between like this. They will normally see. Suddenly, they may close like this with very forceful this one. That is blepharospasm. Then writer's cramp. Some patients, if you give a finger, if you give a pen and ask them to write, while writing they'll suddenly get a jerks like this. Okay, they'll suddenly get a jerks like this. That is writer's cramp. Okay, these are some focal dystonias which you get. So the next involuntary movement is a tremor. What is tremor? Tremor is a rhythmical, repetitive oscillations of the agonist and antagonist muscle. Tremor is a rhythmical, repetitive movement because of the agonist and antagonist muscle action. Tremors can be fine like in a thyrotoxicosis, or it can be a coarse like in an alcoholic tremors. It is mainly classified into resting tremor, postural tremor, intentional tremor. The resting tremor you get in a Parkinsonism disease, okay, which disappears with the action. The postural tremor is mainly demonstrated. The postural tremor is seen in thyrotoxicosis, alcohol intoxication, physiological tremor, anxiety, and drugs because of sympathomimetic drugs. Okay, that is a postural tremor. Okay, next is intentional tremor. Intentional tremor, classically it's seen in cerebellar disease, which we discussed in the last class. Intentional tremors. Okay, so that is briefly about the tremors. Okay, next is myoclonus. What is myoclonus? Myoclonus is a sudden shock like jerky movements of the body. Suddenly patient will be doing like this, a jerky movement of the body, that is myoclonus. Myoclonus can be a normal, okay, when the patient just is going to sleep, okay, at that time there can be myoclonus. It can be pathological. Pathologically, myoclonus is usually seen in metabolic disorders like hypoglycemia, hypocalcemia, renal failure, liver failure, respiratory failure. There are two neurological diseases which produce myoclonus: subacute sclerosing panencephalitis, okay, and also juvenile myoclonic epilepsy, and Creutzfeldt-Jakob disease. When we were discussing 9th and 10th there is one more myoclonus that is known as palatal myoclonus. Palatal myoclonus, the problem is in the triangle of Gillian and Moller, right? It is a triangle involving the dentate nucleus, the olivary nucleus, okay, inferior olivary nucleus, dentate nucleus, red nucleus. Okay, the problem is in the connection between these three nucleus. There are palatal myoclonus. Okay, right. So myoclonus can be a physiological or pathological. Next is fasciculations. Fasciculation is a contraction of the muscle fascicle. Fasciculation can be seen, can be palpated, can be auscultated. There are some maneuvers which induce the fasciculations. If you put the muscle into action, or if you tap the muscle, if you put ether on it, hyperventilation, hypercaffeinism, physostigmine, pyridostigmine will produce a fasciculation. What are the causes of fasciculation? Fasciculation is the crying of a dying anterior horn cell. So, disease which affect the anterior horn cells. For example, motor neuron disease, syringomyelia, any spinal cord disease which affect the anterior horn cell will produce fasciculation. One in India common poison which produces fasciculation is organophosphate compound poison. There are two myopathies which produce fasciculation. Fasciculation is not a feature of myopathic disorders, but only two, thyrotoxicosis and carcinomatous myopathy, may produce fasciculations. Fasciculations can be produced by physostigmine, pyridostigmine. Fasciculation can be a benign also. Okay. What is fibrillation? Fibrillation is a contraction of a single muscle fiber. It cannot be seen, but the only place it can be seen is the tongue. Fibrillation. So, fibrillation is a contraction of a single muscle fiber. Fasciculation is a contraction of the muscle fascicles, and myokymia is a contraction of the multiple muscle fascicles. Sometimes the muscle fascicles can contract and produce a small jerky movements of the fingers. It is known as mini polymyoclonus. Okay, so this is about the involuntary movements. So we discussed in the motor system, the nutrition, tone, power, coordination, reflexes, involuntary movement.